Hello and welcome to this roundtable discussion for blood cancers today on myelofibrosis. I'm Prithviraj Bose from the Leukemia Department at MD Anderson Cancer Center in Houston, Texas, and we are all here at the ASH annual meeting in San Diego, December 2024, and I'm joined by three illustrious colleagues and I'm going to ask them to introduce themselves.
Hello everyone, I'm Francesca Palandri and I am a medical hematologist at the Università di Bologna in the north of Italy, and I am particularly focused on the treatment of chronic myeloproliferative neoplasms.
Hi, I'm Andrew Kuykendall from Moffitt Cancer Center in Tampa, Florida. I'm a clinical researcher focused on treating patients with myeloproliferative neoplasms as well.
And I'm Lucia Masarova from MD Anderson Cancer Center in Houston, Texas as well, and I'm also focusing on myeloproliferative neoplasms.
So Andrew, why don't you bring us to speed with where we are in the therapy and the treatment of myelofibrosis, understanding that we have 4 agents approved, and maybe just bring us up to speed to where we are, and then we'll get into some of the nuances.
Yeah, absolutely. So Prithvi, obviously the great kind of successes we've had in treating myelofibrosis have been the advent of JAK inhibitors. So in 2011, we had the approval of ruxolitinib based upon the COMFORT-1, COMFORT-2 studies. These studies really show that ruxolitinib is quite effective at reducing spleen volume, improving disease-related symptoms, improving quality of life, and actually conveyed to a survival benefit. The downside of that was that the main side effects we worry about with ruxolitinib were cytopenias, anemia, thrombocytopenia, and so we know that that's also critically linked to the disease of myelofibrosis, and so there was a subset of patients that weren't able to achieve the same benefits of ruxolitinib that maybe others were, and so I think really the next decade or so was trying to figure out how we can extend the benefits of ruxolitinib to all patients, and so in 2019 we had the approval of fedratinib. That moved the needle a little bit because potentially we could treat patients with platelets of 50 to 100,000. It was a slightly different in its study design, the Jakarta study, but really it didn't make a huge impact on the field until we got the accelerated approval of pacritinib, which is an agent that's a JAK2 inhibitor, spares JAK1, hits also IRAK1, FLT3, as well as ACVR1, and has the ability to be used safely and get the same symptom and spleen responses in patients that have marked thrombocytopenia, very low platelets, which is really a minority of patients, but a significant minority of patients that we didn't really have any options for. And then really last year we had the approval of momelotinib. And momelotinib was an agent that's really been in development for a while, but was distinguished by its ability to maybe be more favorable or even improve anemia, right? And so this is clearly something that's really linked to the disease. Many patients present with anemia. Nearly all of our patients have anemia at some point in time. And frequently these patients, when they got on ruxolitinib, may be pushed into needing blood transfusions and things like that. And so the approval of momelotinib, which has a label for myelofibrosis and anemia, really extended this ability to achieve or benefit from JAK inhibition to most patients with myelofibrosis.
No, absolutely, and as you point out, Andrew, we need, even though they're all in the same class, we need all four because they have their nuances. There are areas where they fit best, and certainly it's a welcome addition, all of these, to our arsenal. Now, Francesca, we have learned a lot about ruxolitinib from you, from all the real-world studies that you've done. But tell us, now that I think it's fair to say that momelotinib is the main new addition over the past year. What is your experience been on clinical trials or perhaps even compassionate use? I understand you don't have it yet in Italy for commercial use, right?
No, in Italy, momelotinib will become available at the beginning of 2025, so we are using it only in the expanded access program, and we have the experience in clinical trials. What is important is that we knew from previous experience that ruxolitinib is a terrific drug. It can achieve spleen and symptom responses, prolonged survival, but it has no significant activity in patients with a cytopenic myelofibrosis. We have demonstrated it in many previous papers on large cohorts, and we observe that if a patient has a low platelet count, if a patient has anemia, this patient is generally treated with low-dose ruxolitinib and is not going to get any significant benefit from this drug. In this setting, momelotinib may be beneficial because not only achieves spleen and symptom responses, but also can improve the levels of hemoglobin. For example, from the clinical studies, I was really impressed by the burden of a transfusion need of the patients that significantly decreased while on momelotinib compared to ruxolitinib when they switched from ruxolitinib to momelotinib second line. And also in the SIMPLIFY-1 trial, there was a comparable spleen response, actually a lower symptom response, but a significant improvement in the transfusion independence rate. And this was very important for the prognosis of the patient, because there was a significant association between the status of transfusion independence at 24 weeks and the survival prolongation. So I think that this is important data that may complement and expand our ability to treat the patient with myelofibrosis.
Absolutely. And Andrew, you are one of the major enrollers, if I recall right, on Momentum. What was your experience on the trial?
I think first of all, the experience was that patients really were motivated to go on the study, right? Which I think represents that you're doing a study that's going to benefit patients, right? When they're very excited about something. And so we'd known from SIMPLIFY-1 and SIMPLIFY-2 that momelotinib is an agent that has impact on spleen and symptoms, but tends to be more favorable on anemia. And we have lots of patients in our clinic that are on ruxolitinib that are dealing with anemia, right? But they don't want to stop the ruxolitinib based on how they feel. And so really was quite an easy trial to enroll on because you had motivated patients. Now, we were able to put patients on, typically these were patients that had been on ruxolitinib, usually quite recently, or if they weren't on currently, and they had splenomegaly, they had some degree of symptoms, and they were anemic, right? So hemoglobin had to be less than 10. And then what we experienced is those patients that went on really were able to maintain the same symptom benefit, and we saw changes in those hemoglobins over time where they were needing less transfusions. When you look at the results of Momentum, it bears out what our experience was as well. So you have kind of the primary endpoint of that study was a symptom benefit. Patients felt better at week 24 when they were on momelotinib compared to danazol. They also had better spleen responses, as you would imagine, compared to danazol. And really encouragingly, you actually had higher rates of transfusion independence at week 24 when you had comparable rates of transfusion independence at the start of that study.
So Lucia, tell me this. It's been discussed that danazol was kind of a unusual comparator in the Momentum study. What are your thoughts on the use of that as the comparator?
Yeah, well, danazol has been used for the anemia in these patients, and actually even in this study it was quite surprisingly effective. Mm-hmm. So it's not a placebo drug. It is really a drug that was used, and it's been added even to ruxolitinib for anemic patients. So especially in our institution, we kind of use it for quite over years, and it proved to be effective agent. And I think it's one of the best that we can compare to. So rather than just using nothing, that was a very smart choice to really show where does the anemia benefit could fit in and what patients could actually experience with this.
So an active control for anemia in a post-JAK setting.
Yeah.
Now you and I have used a lot of course, momelotinib commercially since its approval. Well, what has your experience been with the commercial product?
I think particularly encouraging is, as been mentioned, the anemia benefit improvements, because it happened very quickly. Within a month, there is like 1 gram of hemoglobin improvements, and a fantastic point what Andrew just said, excitement. Patients just got so excited because we started them, they come to clinic every other week, need transfusions, spend their hours, and then they become transfusion independent. So they all of a sudden don't have to come that often, they really have a bunch of their life back. And there were now the post hoc analysis, all of these studies showing there's a time saving of that, basically the most important thing. They don't have to go to clinic, get checked out, spend their life in the clinic. So I think that time saver for these patients is an absolute win. And we've seen it in the clinic. We all feel more comfortable when our patient is not living in the hemoglobin of 7, something's going to happen to them, they're not symptomatic. There is a benefit on the spleen and symptom control, so it's not only an anemia drug, it's the whole myelofibrosis complications drug. So that actually that would be the most important. Immediately it came in, patients were so excited. Oh, we have new drug on the market. I've been suffering this anemia for months and months and months. What are we gonna do about it? So that was a very exciting switch, where we sometimes have the drug approved that we'll just put aside and wait for the next line when it comes in. But now it was much more, and we've seen it in the clinic and in the community practice. People were more eager to, okay, now we know what this drug can do. We've seen the anemia, it happens quickly, so we don't have to wait 3-6 months to see the turnaround. So that was, I think, the major point where people are using it much more in the clinics than other drugs, including drug inhibitors that were approved.
Now, Andrew, you mentioned motivation. Lucia, you mentioned excitement. And that reminds me, in my career, I have not seen this much interest on the part of patients for any drug. And chatting with Francesca a little while ago, You've seen the same sort of thing in Italy,
Yes,
right?
yes, actually, also in Italy, the patients are coming and referring to the clinics and asking for what's new, and they specifically refer to momelotinib if they are anemic. So momelotinib is really becoming something exciting from a medical point of view, but also from a kind of psychological point of view, because it can be very resourceful for this setting of patients.
And as you said, Lucia, one drug that can address kind of all three cardinal aspects of the disease. No, absolutely, and my experience too has been very favorable, particularly on the anemia front. I think in the second line setting where there's more use of it, right? At least today, I think more of the use is in second or later lines. I found it to perhaps not be as strong for spleen and symptoms as for anemia, but the anemia effect is absolutely quite striking. Do you guys agree with, has that been your...
Definitely. And also, I think that one thing that is very important to the patient is the tolerability, the general tolerability.
Absolutely.
And that is a strong point in favor of momelotinib, because we have very few extreme hematological side effects. They are very manageable with transitory dose reduction. So this is perceived also as a safe drug and easy drug to take. And also we can maintain the dose intensity.
Absolutely.
So while we tend to decrease the dose with other JAK2 inhibitors, momelotinib generally keeps 200 milligrams once a day, also in the case of low platelet count and anemia. And this is very important because it may be connected with a higher probability of long-term response and survival, who knows?
Absolutely, dose intensity, right, which is the struggle with ruxolitinib in the cytopenic pain, as you have shown. Now, with regards to tolerability, right, like what have folks, if anything, noticed as being potential issues with momelotinib? I found it generally very well tolerated, of course.
Yeah, when you look at the clinical trials with momelotinib, you get the sense that it's pretty well tolerated, right? And when you compare it to other JAK inhibitors, I think what's distinguishes some of the tolerability with pacritinib and fedratinib is this GI toxicity that was seen in high rates. Now, this is a GI toxicity with those agents that probably can be mitigated with antiemetics and counseling and antidiarrheals as necessary, but ruxolitinib really had quite low rates of that in its clinical trials, and momelotinib very much reflected those low rates. There was one study that showed that maybe there was a little bit more nausea with momelotinib compared to ruxolitinib, but the rates of diarrhea were quite similar, and still overall the rates were low. I would say since approval and since commercial use, that's been really what's mirrored. There's some GI toxicity, just like there is some with ruxolitinib as well, but it pales in comparison to what we see with other JAK inhibitors. Early in the development of momelotinib, there was a concern for peripheral neuropathy. Didn't see so much of that in the MOMENTUM study, but something I do keep an eye on in our patients. We've had some that have some peripheral neuropathy. I think that's very difficult to necessarily attribute to the drug or not, as that is a common symptom in patients, especially as they get older and have vascular issues, which many of our patients do have, but something to keep an eye on.